All right, we are live with our session 4, and our topic for today is expert opinion on telemedicine, digital health, and primary health. We have three speakers with us today. We have Sadaf Mustafa from US, and then from Pakistan we have Iffat, Zafar, and Kamran Iqbal. So I'm going to first introduce the heavy profile of our guests. Each of them are well experienced, and they are excel in their fields. So Sadaf Mustafa, her specialization is basically internal medicine and obesity medicine. She's currently director of Med Management Clinic at MedStar Union Memorial Hospital. She's also assistant professor at Georgetown University, a faculty physician at MedStar Health Internal Medicine North, and a primary care physician at MedStar Medical Faculty Practice. And I'm going to introduce now to Dr. Iffat Zafar. She's an e-health expert, and she's currently the Chief Operating Officer at Sehat Kahani, and a Global Good Fund Fellow, a Commonwealth Scholar, and a Microsoft featured social innovator. And I'm gonna next move on to Dr. Kamran Iqbal, whose expertise lies with primary and public health. And currently, he's an expert and consultant for public-private partnerships at World Bank Group. He's currently a Bernard Lowndes Scholar at Howard T.H. Chan School of Public Health, and he's also the founder and curator of Global Shapers Community. The Ziauddin Alumni would like to welcome you all, the self-funded and self-made ZMC alumni.
So hats off to you guys, yeah.
It's amazing. It's a lot of hard work.
Yeah, it's a lot of fun. Yeah.
It is.
So I'm gonna our first question to start with Sadaf. It would be really interesting to know what is the structure of telemedicine in US, and it would be nice to break it up before COVID and post-COVID scenario.
So the way it works here in the United States is that there are 4 different, I would say, subcategories, the way you can actually do telemedicine. And the same was before and after the COVID, but there were some rules that were made more flexible after the COVID. The very first one, or I would say the most simplest one, is just pick up a phone and call, which are known as virtual check-ins. These are time-based codes. The second one is video visits. These are also known as synchronous because you're able to see your patients. These are the same as face-to-face visits, and they are reimbursed at the same rates. Here, those codes are known as E&M-based codes. The third ones are the portal, or the time that you spend with the patient, communication through portals or phone calls, but they are not the phone calls that you do with a scheduled appointments. And the last one are remote monitoring, like blood sugar, pulse ox, blood pressure. These things are just some common example. Now, before COVID-19, CMS had some fixed rules and regulations that were supposed to be followed. Like the patient needed to be in a specific location, not really at their home, where you will be reimbursed. But when COVID-19 pandemic happened, they made this simple and allowed the physicians to actually access the patients at home. And you can actually talk to the patient while they are at their own residence. That was a big change because it opened up doors for all the physicians to reach all the patients everywhere. And CMS basically made it very clear that they will reimburse these visits. Usually the commercial insurance follow the pattern of the Medicare and Medicaid reimbursement models. So the other commercial insurance kind of followed that pathway. The other nice thing that happened was before COVID-19, if I am in Maryland, my patient is supposed to be in Maryland, right? Yeah. Now, after COVID-19, this happened that like now my patient can be in Washington, D.C. and I can actually see that in Washington D.C. Now, every state has made some changes to allow other state licenses, and those are they all vary by state to state, that which state can see which other state licenses. But that was the other nice thing that happened. But obviously telemedicine, despite of the fact that it has has a lot of laxity, has still some restrictions, like if you are having say telephone visit, you have to make sure that it should not result in another visit in the next 7 days, which is a face-to-face visit, right? So you need to be careful about these certain rules before you do them. Those are pretty much big bullet points that I can recall that has been happening, but they've been very, very helpful. Especially allowing us to reach our patients at home, with 65 and above with multiple chronic comorbidities has been very helpful. Yep.
Okay. Iffat, I would like to ask you that how has telemedicine evolved after the current pandemic in Pakistan specifically, because you deal with that?
So, first of all, thank you so much for arranging such an amazing session. I think what you and Fahim are doing is exceptional, given the fact that you're leading this alumni without a lot of support. And heads off to you guys. I think that the major change that happened post COVID was that there was a lot of inertia in accepting telemedicine as a solution in Pakistan. And I think we are the kind of nation who still want to have that physical touch of a doctor. And वो कहते हैं ना, नब्ज देखेगा डॉक्टर तो सही इलाज पता चलेगा, वरना it's not going to work out. So I think the best thing, which is very unfortunate, but I think with this current COVID crisis, the best thing that happened for Sehat Kahani and for telemedicine is that people actually got a chance to have a flavor of it. I think with Sehat Kahani, we are getting two kinds of patients. So the first category is regular ailments for which a person is unable to access any doctor because all the OPDs are shut down. So we're getting a lot of patients with diabetes, with cardiac follow-ups, with even complaints that are slightly difficult to cater through telemedicine, such as dentistry. But then they're like, there's no other way out. And the numbers have jumped tremendously. So for example, if we were having 50 to 60 consultations in a day, it has jumped to having 600, 700 consults in a day, where we had to literally hire an entire army of 100 plus doctors, more like running a virtual hospital altogether. But I think apart from the regular ailments, an important surge that happened was a lot of people who might have the fear that they're developing COVID, or they've had exposure, or they've traveled. So a large number of patients who started accessing the applications essentially are people from this category who are worried that they or their loved ones might be suffering from COVID, or they might have had some exposure, and they want to talk to someone to understand that how this works. So I think really with COVID, the inertia has definitely broken. And people from all walks of life, all income brackets, are willing to try out telemedicine and speak to a doctor on a video call, and the acceptability has grown tremendously. So I think that has been my experience.
Can you kind of just give us a small idea of what the structure is like from local telemedicine
of the company?
Yeah.
So Sehat Kahani essentially means story of health in Urdu. And the idea is that how can female doctors who are not being utilized to their full potential, or who are not able to work to their full capacity, come back and be able to give back through the digital medium. We have doctors who are gen physicians, we have doctors who are specialists, we have doctors who are mental health experts. And the beauty about telemedicine is that the doctors who are on my panel are sitting all over the world. So they're not just confined to Pakistan. All they need is a valid PMDC license and the authenticity to be able to practice in Pakistan. But For example, Dr. Sadaf could practice through Sehat Kahani platform and be able to treat a patient in Pakistan. The company structure essentially involves two verticals. We have a vertical which involves creation of telemedicine clinics in low-income communities. So it's like a regular clinic which is run by a nurse who's physically present in the clinic, but then she facilitates online consultation with doctors who are online. And the idea to keep this physical touch essentially is that in communities, A, people lack smartphone access, B, there's a lot of trust issues. So for example, अगर smartphone होगा भी तो they wouldn't be able to access a doctor themselves, but having that nurse who they trust, who they can touch, who will take their blood pressure essentially, makes them more comfortable. But last year we also launched our mobile application, and it's catered more to the urban market for people like you and me, so that we can access a doctor online. And I think the best response has been for the application in this COVID crisis.
Okay, so I'm going to bring in Kamran into this discussion. In Pakistan, virus is not the only one which is novel over here. It's the digital and telemedicine, terms which are like 70 to 80% of the society in Pakistan population doesn't know about. So would you like to bring in the light? How do digital health and primary health work together? Do they synergize? And how important it is to Pakistan to move to digital health?
Right. So first of all, thank you, Fahim and Dr. Huda, for such an amazing opportunity. And I also want to take a quick moment of gratitude for all those people who are at the front line fighting this invisible enemy. And they are the absolutely amazing people. आर्मी के सामने तो एक वो दुश्मन होता है नजर आ रहा होता है और उसे लड़ना होता है, उसको आप कंटेन कर सकते हैं, कुछ नहीं तो निगोशिएट कर सकते हैं. यहाँ इस एनिमी के साथ कोई निगोशिएशन टेबल नहीं है, राइट? और वो इनविजिबल भी है. So ये जो डॉक्टर्स जितने फाइट कर रहे हैं ना, they are really fighting the war which even a military cannot fight. So hats off to them. Either they are digital or in a person. It's an equal sense of gratitude I have for all of them, and people who are working indirectly to support them. Absolutely, thanks to them that a lot of people are still safe. So coming back to your question, right? Primary healthcare देखिए पाकिस्तान में के लिए बहुत क्रिटिकल है. डिजिटल हेल्थ को हम लोग बहुत अंडर एस्टिमेट करते हैं, लोग उसको एज ए लग्जरी लेते हैं. भाई इट्स वेरी वेरी क्रिटिकल फॉर अ कंट्री लाइक पाकिस्तान. देखिए पाकिस्तान के मेजर प्रॉब्लम है तीन हेल्थ केयर के: एक्सेस, affordability, and quality, right? And we all agreed with it. I don't think so there is any different opinion on this. So digital health, what it does is that it is affordable, accessible. Quality is something, it is an ever growing thing, right? Clinical effectiveness with time build की जा सकती है. तो digital health lowest cost possible में high volume पे मरीजों को देख सकते हैं digital health platform के जरिए. So primary health care के लिए एक बड़ा complementary layer है. Pakistan, it's a must-have. It is not should have; it is a must-have thing. So this is what is so important. How I see digital health in Pakistan evolving, and this is I'm speaking from my personal experience of I had an opportunity to be working at Sina, where we created our own small digital health, treating about 1 million patients in a year, right? So my learning from that for last 3 years have been that Pakistan with digital health would eventually go pre-primary level of healthcare. Actually, when I say pre-primary, which means that people before going to primary healthcare clinic would go on their mobile, get a first level consultation at the digital platform, and for examination purpose, to validate, have a second opinion, to see a doctor in person if it is complicated enough that it cannot be addressed by digital health, then they will go to primary healthcare. So aista direction is taraf jayegi, because digital health platform can see patient at high volume, right? And it can address a lot of challenges in Pakistan, number one. Number two, this coincides with nursing people needs to be adopting or kind of role उनको shift करना पड़ेगा basically towards physician assistant, like the one you see in US, right? Because in Pakistan digital health की regulation अभी बनी नहीं है, so it's an open field, right? Which is good for innovation, But when it comes to risk management in terms of patient care, it is a minefield actually, right? So there has to be a wise pro innovation, pro digital regulations की need है, जो कि innovation को choke ना करे, बल्कि उसको promote करे while protecting patients' interest, data and privacy and all, right? So अभी open field है. इसका फायदा ये है कि it can rapidly penetrate. अगर आप global innovation के sense में देखें, तो पहले healthcare होती थी, clinic में, क्लिनिक से गई डिवाइस पे, डिवाइस से गई वॉच पे, अब ये इन्वेजिव हो जाएगी, ठीक है? सो जो पब्लिक हेल्थ की डायरेक्शन जा रही है वो तो होमवर्ड जा रही है, घर की तरफ जा रही है बेसिकली. इट इज कमिंग इज गोइंग फ्रॉम द सेंटर बेस्ड टू द होम बेस्ड. सो डिजिटल हेल्थ इज द ब्रिज विच टेक्स इट टू होमवर्ड्स. सो अल्टीमेटली डिजिटल हेल्थ की जो लेयर है वो प्राइमरी हेल्थ केयर में डॉक्टर के पास जाने से पहले एक लेयर बन जाएगी. नंबर 1. जो दूसरी चीज इंपॉर्टेंट समझने की जरूरत है कि आप प्राइमरी हेल्थ केयर में आप डिजीज को एट व्हाट कॉस्ट पॉइंट एड्रेस कर रहे हैं, उसकी सोशियो इकोनॉमिक्स ऑफ ट्रीटिंग द डिजीज है. जब मरीज का ऑलरेडी डिजीज हो गया है, वो क्लिनिक में एंटर हो गया है या हॉस्पिटल में एडमिट हो गया है, तो आपका जो ट्रीटमेंट का कॉस्ट पॉइंट है या प्राइस पॉइंट है वो बहुत हाई है एक्चुअली. So digital healthcare, you can actually address this challenge at the cost point, which is way earlier actually. So you can actually dramatically decrease downstream cost of healthcare. So this is why it is relevant. Third most important point when it comes to primary healthcare and digital health is the granularity of data, right? Most of the primary healthcare is very near to community, right? Because facility based or at home based. Right, which means that you can get a granular data, which you can build a solid forecasting model, which has a good relevance, strategic relevance to public health surveillance, basically disease surveillance, especially infectious disease surveillance, and long-term monitoring of chronic diseases, non-communicable disease. So these are like very, very critical reason why a digital health is a must-have thing. It's not a luxury. It must have. So I suggest to my fellow doctors and a lot of people who have not been into digital health is to really adapt faster, right? It is a matter of staying relevant to your field, right? It is that important actually. जैसे अभी watershed moment हुआ है, ये पेंडेमिक ना पहला है ये पेंडेमिक, ना ये आखिरी पेंडेमिक है, राइट? ठीक है. सो वी हैव टू अंडरस्टैंड दैट ये वाटरशेड मोमेंट के बाद नेक्स्ट मोमेंट इसकी डेप्थ की बात आएगी. सो जितना जल्दी हम डॉक्टर हज़ार अडॉप्ट कर लें इसको और इस स्ट्रीम को अपने आप को ट्रेन के लिए, उतना अच्छा है. और मरीज के लिए बहुत कंफर्टिंग होता है कि एक कॉल पे एक ऐप के जरिए डॉक्टर एक्सेसिबल होता है. वो बात अलग है, इसकी अपनी लिमिटेशन है कि एग्जामिनेशन नहीं कर सकते, वेल एटलीस्ट डॉक्टर इज एबल टू गाइड, ठीक है, विदाउट वेस्ट अ लॉट ऑफ टाइम. सो दीज आर माय फ्यू suggestions on that. Yeah.
Okay. Sadaf, I want to bring you in, and since the US is ahead, way ahead than Pakistan in having a digital health platform and telemedicine system, so it would be really nice for us to learn about the triage, telemedicine triage system and screening criteria, especially for COVID-19, which the US and your hospital maybe is following.
So before I start, I really want to acknowledge my teachers, because the kind of skills they taught us about physical examination were amazing. And now that we all are doing telemedicine, it seems like all those skills are coming back, predominantly the hardcore history taking. You have very minimal hands-on your patients. So what really is important are the questions that you're asking from your patients and differentiating, because everybody's panicked. Like the questions you're getting, I'm short of breath. And you're like, okay, how long? For 4 months. And you're like, okay, well, let's go ahead. So I'm just giving you an example, but I would say, guys, go back to your basic history. Physical examination may be a little challenging, but we have a different way of asking questions. They may actually incorporate your physical examination kind of skills or tools that we have learned. But I will try to share my screen and see if I'm successful in that, okay? And if I am, that would be amazing, because then I can actually really show you what I want to show you. Let me see. Can you guys see the table now? Is everybody able to see a table?
At least
No.
Can you see like a green, red, and yellow table?
No.
No? Okay. Let me see. I was hoping I can share this with everybody. Anyways, so if that's not possible, don't worry about it. So when I receive a call and when I'm speaking to these patients, MedStar has given us a wonderful triage system. What we do is there are two different ways to take this. One is symptomatic and the other is asymptomatic. So symptomatic, we have kind of learned from the previous three sessions, like cough, shortness of breath, loss of sense of taste and smell, having headaches, unremitting headaches, etc., etc. So now, when you have a patient like that, you have to first of all figure out what's the age of your patient, what are the underlying comorbidities of your patient, and what are the living situation and the job of your patient, because you have to make sure your patient is not somebody who's going to spread this in the community. Actually, it's one of the most important testing criteria, because if you have somebody who can spread this in the community, despite of the fact that the person is relatively stable, it's one of the criteria to get that person tested. So therefore, like public servants, like EMS, healthcare workers, um, people working in shelters, people working in nursing homes, all these have to be tested, even with minimal symptoms. Now, if you have somebody who is more than 65 years of age and still have symptoms, right? Minimal symptoms, you can make a judgment call. So the people that I mentioned, before are called as green, meaning you have green signal, go ahead and screen them because, they needed to be screened. Now, you have somebody who had immunocompromised condition, transplant, right? You have somebody who already have a cancer, is on immunosuppressant, and multiple other conditions which are causing the immune system to go down and have symptoms, even mild, you will test them. Okay. Now you have somebody who is young, like I have a 32-year-old diabetic. I know diabetes causes compromised condition, excuse me, but my patient is young and can probably be managed at home. In these people, I would rather follow them linearly than testing them. And actually, this was happening more when we had less amount of testing kits available than now. Now they are encouraging us to even get these people tested, because now, the mayor has had more testing made available to Maryland. But perhaps, see, for example, you want to apply this in Pakistan or any other state that has limited testing facility, you can quarantine these people at home. I've been doing this since this pandemic came, and we are just fine. We were able to longitudinally follow them, and if required, test them on as needed basis. Now, this is the yellow group where you can test them or not test them depending upon how the person is doing. Now, there's another zone which is red. Like, for example, my patient called, he's 40-year-old, perfectly fine, no medical condition, telling me my mom is positive with COVID-19. Well, what's going on with you? Nothing. What's your job? I don't do anything. I'm not going to screen that person. Yeah, even if that person is positive, my management is not going to change. He's going to quarantine exactly like their mother. Going to stay home for 7 days, see where the symptoms are going, improving or not, and then go from there. So it actually allows us to really narrow down the people into three different categories. This is the people who are calling me for testing. Now, say, for example, I have already know the symptom and I already know the results, positive or negative. And what to do with the quarantine? That's a very common question that comes in. If I have somebody who is a non-healthcare worker, right, and is not somebody who is working for public safety, I would have to let that person quarantine at least for 7 to 10 days and can only go out in the community once is symptom-free for 3 days. But say is the same person, but is not a healthcare provider, can actually go out in the community after a week of quarantine if symptom-free for 24 hours. And this is all by CDC guidelines. And it is changing. Like in the beginning, it was everybody 2 weeks, not going to go for 2 weeks. And now it's coming down between 7 to 10 days. And then depending upon if you are a healthcare worker, not a healthcare worker, public safety worker, not, depending upon where you are. Say, for example, somebody is really high risk and the COVID is negative. It also depends upon, again, where the person is, right? Where the person is working. If it's a healthcare worker, again, you have to make sure staying home for 7 days and not having symptoms for 3 days before they resume going back to work. So all these things are important, and they are very important part of telemedicine. The other thing that we really, really, really have an issue is with people trying to stay home and not go to work, because it's a lot of panic going on. They don't want to go to work, despite of the fact that we are encouraging people to not to bust the economy. I'm getting a lot of depression and anxiety. But you can do the best that you can do, but obviously you cannot really do more than that. But that's something. But that's basically the triage system that MedStar has given us, and I feel like it's working just fine. I've not had any major issues.
Okay. Thank you, Sadaf, for such an elaborate, idea about how your system works. Iffat, can you tell us the role of Sehat Kahani platform that your platform plays in current COVID situation in Pakistan? How are they tackling the situation?
So I think in the current COVID crisis, what Sehat Kahani has done is that we have recently partnered with Digital Pakistan, and what we've done is that we've made the application free for the next 3 months for everyone to use. Apart from making the application free, and I was just listening to what Dr. Sadaf was also saying, we have trained our doctors for the entire SOPs and the management and screening of COVID suspects. So the idea is that, again, history becomes very important, asking the right questions. And Pakistan में जो national guidelines के तहत उन्होंने questionnaire release किया है. So what we did was we trained all of our doctors based on that. So what the doctors essentially are trying to identify is the seriousness of the ailment, God forbid someone turns out to be a suspect. So for example, if it's a milder version, that they're training the families of how they need to be quarantined at home, what are the measures that they need to be taken, or if it's something serious, then they are referred. So from our central database, hota ye hai ki all of the suspects are recorded. Then they're based on their severity, either trained for home quarantine, or if it's serious, then they're referred to the government authorized quarantine and screening centers. And that list is being updated constantly by the government, और जब वो update कर रहे होते हैं list, तो फिर हम अपने पास भी update कर रहे होते हैं, and we're frequently sharing that with the doctors. Once they are referred, then our centralized team follows them at day 4, day 7, and day 10 to understand their journey. That did they actually did the symptoms get worsened? Were they quarantining themselves at home? Are the symptoms getting better? In case the symptoms were worsening, did they go to the hospital? What were the results? And by day 10, we have a clear picture कि क्या इस patient को corona हुआ था या नहीं हुआ, and so forth. So I think in the last 20 days,
Yes, go on.
So I think in the last 20 days, we've seen around 15 to 16,000 patients collectively. And isme se, I would say 10 to 15% were the ones who were suspected to have corona, and then they were followed up for their journey, that whether they're quarantined or they're screened. So that's what we are doing during the current corona crisis.
Somebody has asked this question, that does Sehat Kahani refer patients to tertiary care hospitals?
Yes.
So I would like you to answer it in this same.
So yes, we refer patients to tertiary care hospitals. जैसे मैंने पहले बताया कि corona patients तो definitely उनको पूरा एक referral letter, एक referral tag जा रहा है to the authorized centers. But for example, a non-COVID patient, some cardiac ailment or diabetic patient also comes to the telemedicine app. So the primary idea of the application is to cater to primary and certain secondary and follow-up patients. So for example, कोई diabetic patient है but stable है, he just wants to understand his readings, his insulin levels, just wants to share the reports, then he can be catered within the app. But if there's a patient who's more sick and needs instant referral, then that patient is immediately referred to the nearby tertiary care hospital, which is भी शहर में मौजूद.
Kamran, I'm gonna have your quick comment on a question by OS. How do you see utilizing chatbots, example, Microsoft HealthBot in telemedicine? Or Iffat or Kamran, anybody of you can comment on that.
If you want to start first, or do you want me to start?
So I can start and then you can add on.
Yeah, sure.
So yes, we are working with Microsoft, and the idea is that ultimately we can get chatbots integrated in the application. I think that would really help us streamline the triage process. क्योंकि triage हर patient instantly doctor को connect कर रहा होता है, but ultimately I think that will be exhausted with the limit of doctors that we can get on the portal, the number of doctors that can actually come. So I think with the chatbot it will really ease out at least the triage part. So it would take around 6 to 8 months to be able to have that in place. And Dr. Kamran, you can add on.
Also, chatbot के sense में language barrier का भी issue is fairly common, right? Because हम तो primary healthcare की बात करते हैं, because real healthcare is a disease जो होता है लोगों को अक्सर घरों में या जहाँ काम करने जाते हैं वहाँ पे होता है, community में होता है या home पे होता है. उसके बाद वो process आके first screening site is a primary healthcare clinic, right? That's the lowest cost point where intervention can take place, the lowest cost point. So chatbots जो है digital health के sense में, just like she mentioned, Dr. Iffat mentioned के it helps in the triage, but ये I guess the language barrier is one limitation given Pakistani context. Unless के patient कोई पढ़ा लिखा है urban settings है तो वो तो फिर भी handle हो जाएगा, right? So that's the bit of a limitation that I see. But I think people are smart enough to circumvent that language barrier future, because healthcare need is so high at the end of the day. Number one. Additionally, a chatbot can be a good resource for history taking, actually, right? Where a lot of data initially can be gathered, which can save a lot of time of a physician, because history taking is time taking in taking part in digital health context. So chatbots will slowly, gradually take that place, right? Anything to help physician for digital health would take place. So I think chatbots उसके लिए भी अहम होंगे. जैसे अभी नई apps आ रही हैं, मैं review कर रहा था, जिसमें one can connect to doctor over messages, and then it leads to consultation. A lot of consultation can take place over stream of messages, where history taking can be taken care of by a doctor, right? And if the doctor think that this patient need video-based consultation, they can opt in for that. So chatbots can really help save precious human resource, time part of the human resource, of expensive human resource that are doctors actually. So this is how it's going to work. Also chatbot are a good source for gathering data for surveys, patient feedback, right? How their experience has been for a particular doctor or a clinical experience. So chatbots are also very important for quality assurance purposes. Yeah.
Okay, so Dr. Sadaf, I'm going to bring you in and have first a quick comment on chatbot, if there's an experience in US. And the real question is, going forward, the impact of COVID-19 on chronic patients, patients having chronic conditions, and they're not being able to have face-to-face examination and clinic experience. Yeah. And especially the limitation of telemedicine with the elderly patients, who do not have a mobile phone, which they can easily, use with video conferencing and these kind of things. Yeah.
So with the chat box, I actually had a little bit of personal experience. And yes, they have already been incorporated, and it depends upon which company you are working with. You can use them, and they are very effective with personal experience. You can very easily communicate with the patient, and as Ifat mentioned, it will eliminate a lot of fatigue on the physicians, and it can appropriately triage the patients that are required to talk to you. Like with MedStar, with this COVID-19 pandemic, they have partnered with another company, which is allowing the physicians to for deployment. And we are actually working as telemedicine physicians with them, which is other than the primary care job that we have. But it's a deployment. It's volunteer. You want to do it, do it. Don't want to do it. Nobody's asking you to do it. But it's an interesting experience. So that's one. Actually, before I go, there's one question that's constantly bothering me here. I'm looking into the live comment. Somebody's asking that they are in Saudi Arabia and their hospital does has an app, but there's some issue in the app and there are multiple loopholes. So actually, you can do all these visits with anything and any kind of device that you want to. Doxy.me is HIPAA encrypted that can be used. Zoom also has HIPAA encryption. If you want to purchase the HIPAA encryption type, your patient information will be saved. Again, it's a video facility that you have. Obviously, you have to put the information in your EMR. It will bridge that patient doctor interaction, and you will be able to speak to the patient, and you really don't have to use your personal information. I hope that answers your question. Now, going to the real question of chronic medical conditions, yes, a lot of my patients have a flip phone. Ta-da! I'm a surprise. And thanks to virtual check-in, I can use the billing codes which are allowed by Medicare. And luckily, so far, seems like they don't have a copay with that. Now, you have to be very careful when you work with a geriatric population. Some of them have Alzheimer's, so you have to be very careful. If they have any issues with dementia, you have to get another family member to be there so that they can verify, and they're actually the one who are speaking on your behalf. So you have to make sure who the person is, document the name of the person, make sure you can verify the medications with the other person. That's another thing. You have to make sure that you repeat what you're saying. Say your patient doesn't have dementia, but he is like, I have my patient, the oldest one is 97-year-old. I just had a video conversation with him, and I was so much happy to see him. I cannot tell you, because he's going through a lot of problems. But I was very fortunate that I was able to speak to his relative and was able to document a lot of things through him. But the important thing, all I wanted to say is that make sure there's somebody there. Make sure you are slow. You're talking very slowly. Make sure you're repeating what you're saying. Make sure they can repeat back what you're saying. I cannot tell you so many times what I am saying
is not what they understand. Yeah.
So do not assume that they know what you're saying. So please be careful about that. They're very hard of hearing, so you need to understand that. Some of them may have stroke, so be patient. I tell them, I can wait. Keep the phone on the speaker. Do what you need to do. Take your time. So that's important. Now, chronic medical conditions. I think, I always say it's going to be ACBC, which means before and after Corona. And that's what's going to happen. We're going to see a lot of chronic medical conditions becoming worse. And thanks to, once again, my training with all my senior physicians that have given us both in the Ziauddin and at MedStar healthcare system, that we are able to now manage these things slowly and gradually over the phone, one thing at a time. But yes, you have to bring these people in a little bit more frequently. You have to maintain blood pressure logs, blood sugar logs. You have to manage everything over the phone. You have to identify the red flag signs. Like I'll share with you, we were able to send a patient with decompensated cirrhosis to the emergency room, able to save cauda equina. So these things, again, history is very important. You're not there to really examine them 100%, and that's a disclaimer that you have to put on your notes here, and you have to explain this to your patients before you make the appointment. You have to it's part of the consent that they understand that your hands are not there, and they have to be part of the physical examination. So yes, the chronic medical conditions most likely are going to become worse, but we're trying our level best as much as we can to manage over the phone. I think it's much better than really not being there. Um, Especially hypertension. Like, I'm surprised how many times they're missing their antihypertensives because they're not just on one pill, they're on 3 or 4 different medications. And out of the blue, they will just stop one of them. Like, there is no reason to stop that. They just stopped it because they didn't had an,
Especially if no that, right?
yeah, like I'm like, अगर मुझसे मिले नहीं 3-4 महीने में तो आप बस छोड़ देंगे? Because I'm like, I'm not the police to remind you to take your medications, but I think it's just a check-in. It's just like, कि पता है वक्त के साथ क्या होता है? You develop a relationship with your physician. So you try to do things for your doctor's sake, not for your own sake. And when that thing goes away, you're like, whatever. I'm not going to take my log. They're going to see it. And so same is the challenge with obesity medicine, by the way, because since they're not going to discuss their weight with me, they're like, whatever. But same with medicine, that's not happening now. I'm still asking them. Go and step on the scale.
Yeah. So we learned a new term, ACBC today from Sadaf.
Before and after Corona.
Yeah, before Corona and after Corona. So Kamran, I'm going to bring you in. And we really need to. I'm sorry I missed out on an introduction about your Pakistan Digital Health Initiative. You're also leading that. So how does it play a role, especially in this scenario of COVID-19? And why do you think it's important to have some digital initiatives? So that would be nice to hear your comment.
So part of that thing, I started like Pakistan Digital Health Initiative like 2 years back, and I'm so glad to know that at least government of Pakistan has started their Digital Pakistan and digital initiative, that is there. So at least there is some alignment and forward-looking progress that is taking place. So there's a sense of alignment there. I started mainly because when I was advising National Incubation Center in Karachi, Islamabad, so there are a lot of healthcare startups out there, and frankly, there are 3 tracks. A lot of these doctors go to. A, they become practicing clinicians. B, they go into health policy management. C, they go to become health administrator. Hardly they go to entrepreneurial track like Dr. Sarah and Iffat are gone there, right? They're kind of creating that example, right? So I see a lot of new smart, intelligent people getting into healthcare, yet they did not have that management experience of running an entrepreneurial way of running the healthcare startups. So I started advising. That's where I found out there's a huge gap in academia, industry, as well as in the government when it comes to digital health. Became the source of starting Pakistan Digital Health Initiative. Another thing that kind of prompted me to started was that I believe that Pakistani government has a huge opportunity to leapfrog in healthcare by making state as the major healthcare data aggregator, right? 2019, and rightly so in 2020, price of data exceed the barrel of oil, price of barrel of oil, right? So you can make the comparison here, right? In US, large part of the corporate yield more power than United States government. Why? They have the largest amount of data, right? Google, Facebook, and the likes have more data than the government have it, right? So naturally, they have more power and more granular insight into how people live, and better intervention plan, has better client service to its users, right? And eventually, they are going to become more powerful, like like East India Company back in those days, there will be a neo-colonization based on technology. One example was Cambridge Analytica and the scandal if you guys have read that, what really happened was the company became so powerful it can change election results actually. So Pakistani government has a huge opportunity whereby government can provide cloud infrastructure and whereby all the digital health fronts, be it hospital or digital health startup, they can park their digital data into government sponsored cloud infrastructure. So that government becomes the major data aggregator, right? So the government can actually monitor the impact of their programs as well as program by local digital solutions. So that is going to create a good partnership, right? Also, if you look at the design in terms of a corporate design vis-a-vis government design, so government has accountability or perhaps public good at the heart of its exercise because they collect the tax and the social contract is designed as such, they're accountable people. But in corporates, they are more than accountability people, they're accountable more to the bottom lines, right? So if the companies are going to become larger and more data, they'll hoard more data, they will yield more power than the government. And who's going to be loser in this are the patients actually at the end of the day. So healthcare will become expensive, right? So I think it's the best moment of time in Pakistan's history that we support the government by helping government become a biggest data aggregator as far the healthcare is concerned. And that became the foundation, the cornerstone of vision behind Pakistan Digital Health Initiative, right? So I have my meeting with Digital Pakistan, this lady, Tania, in coming weeks. So that's what I'm proposing. So that is the whole idea. So I believe that it is possible. But let me give you one example. In 2018, I went to Canada. So I met the CEO of William Osler Healthcare System. It's one of the large healthcare system in Toronto. They have like 3-4 hospitals there, and they see a lot of South Asian diaspora in that. So I was talking to the CEO over there, Brandon, right? So he was telling me that the biggest challenge they have is that they have the EMR there, and their primary healthcare data does not talk to their tertiary healthcare data. It's only recently they have created a new middleware which kind of transport data from primary to tertiary, right? So that the challenge for them, they are not even ready for disruptive innovation. All they can do is incremental innovation. In Pakistan, by doing disruptive innovation, we can catch up with them actually in fast ways, right? By having a policy structure which allows people to park their data in a central database sponsored by the government, where competitive advantage of each company can be protected, where patient privacy confidentiality can be addressed, yet data should be available across the board through obviously right-based or very much exclusively people who can responsibly handle that kind of data. So that kind of granularity can help. This is the whole idea of Pakistan Digital Health. Yeah.
I want to ask a question which just came to my mind, and I think all of telemedicine users will have, and this is question is to all three of you. How much your patient is concerned about privacy of their data over telemedicine? I know there have been issues in the past, so I want to ask Sadaf to comment first, then Iffat, and then Kamran.
So before COVID-19, you can only use HIPAA encrypted service, right? Other than that, none of them were allowed. And that was the reason why this business was very kind of slowly going up, because you need to make sure that you have malpractice insurance. You have to be very sure that the company that you are using is actually HIPAA encrypted. But after COVID-19, actually transiently, that law has been uplifted. You can use Skype. You can use, as I mentioned, Zoom Business. You can use Doxy.me. And you can also use some other, they're not coming in my mind, but they are not actually HIPAA encrypted. And you can still use them. Despite of that, Still, most of the companies are trying to get it HIPAA encrypted and not to use non-HIPAA encrypted resources, because this will become an issue. Although they're saying that you can use whatever you want to use it, but believe me or not, there are going to be so many lawsuits coming from this, and lawyers will be so much rich. But at the end, nothing will happen. It will be so chaotic. And that's why they are still making sure that they, like, we are using like Bluestream, which is HIPAA encrypted. So they have to make sure that the devices, whatever you are using, is HIPAA encrypted. I don't know how it is in Pakistan, or if HIPAA laws are actually applied in Pakistan very properly. I'm not very aware about that.
I think Iffat can comment and then Kamran can take over.
So I think so I'll talk about the regulatory structure and also how patients perceive this. So telemedicine is a very gray area, unfortunately, in Pakistan. And while we strongly believe that it needs to be regulated, there need to be laws around digital health. If you look at the policy structure, we don't even have a digital healthcare policy, unfortunately. And that is good, but that's also bad, because then you're like hanging in the air and you're not sure that the next day someone can come and try to shut you down. But having said that, what Dr. Sadaf was saying, when we were creating the telemedicine platform, because we really want to comply with the global standards, we ensure that the application is HIPAA compliant, because we might not have the regulation today, but we will be having it tomorrow. Also, now with this application, we got patients who were settled in the diaspora. So it's very interesting. US, UK, Saudi Arabia, Dubai, we've been having frequent patients from those areas. But apart from that, we also had a couple of patients from areas such as Philippines, Maldives, Copenhagen, Denmark. And we were like, okay, this is going somewhere. So we really had to ensure that it is HIPAA compliant. It is something that we do. But on the patient perspective, since we are catering to different kinds of income brackets, there's a certain income bracket which is very concerned with, I wouldn't say privacy, but the fear that maybe their wives or their daughters are being videographed, or maybe they're being filmed. And we get a lot of patients who don't even allow their wives to make accounts from their own name. So it's going to be a male name and the patient pops out to be a woman. That's a common finding that we have seen, that they're generally scared to like make their wives make an account. This is one category that we've seen. But having said that, we've also seen a very aware category who's very kind of possessive about their data, and their questions revolve around, is this GDPR compliant? If I, as a patient, ever want you to completely eradicate my data, who's owning the data? And based on the GDPR guidelines, it's the patient who owns the data. And if I, as a patient, ever said to Sehat Kahani that delete all my data, Sehat Kahani has to comply and delete all the patient's data. So these are the things that we are working on, and I think with the collaboration that we've had with Pakistan, I'm so glad that Dr. Kamran is also speaking to them. The more noise comes about and the more players come in the market, I think they're going to really realize the importance that we need to have a policy in place. And I just mention a very funny incident here. I'm finishing my master's in global e-health from University of Edinburgh, and we had to dissect our own country's e-health policy, which we didn't have. So honestly, I ended up dissecting Kenya's e-health policy because that was the most closest. So I was like, Kenya kar lete hain, chalo kuch to similarities hongi. So I think it's high time we need that.
So Kamran, would you like to elaborate on that?
Yeah, interesting perspective, Dr. Iffat, very insightful. इसमें सिलसिला ऐसा है कि पाकिस्तान, अगर आप हिस्ट्री देखें, या तो जो भी चेंजेस होती हैं या तो कंज्यूमर ड्रिवन होती हैं कि कंज्यूमर इतना अवेयर हो जाए, या रेगुलेटर ड्रिवन होती हैं, रेगुलेटर इतना अवेयर हो जाए. आई मीन एक साइड एग्जांपल देता हूँ कि जैसे क्रोमोसोमल टेस्टिंग होती है 23andMe, वगैरह जीनियोलॉजी के लिए, जिसमें आपको पता चलता है कि आपके जेनेटिक डिजीज या जो 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 लीनिएज या जीनियोलॉजी है उसके इसमें इसकी कोई रेगुलेशन नहीं थी पहले, तो अचानक से रेगुलेटर अवेयर हो गया, उन्होंने लगे इतना ज्यादा जेनेटिक डाटा इनके पास जा रहा है, इसका कुछ करना चाहिए और इसमें प्राइवेसी के इश्यूज हैं, तो अचानक से रेगुलेटर यूएस में जाग गया, देन दे काइंड ऑफ रियलाइज व्हेन majority of their large part of the data was gone. So same is the true with the digital health. Either it's consumer driven or it's a regulator driven change that takes place. Also, regulation also follow innovation rather than vice versa. They also try to catch up. Innovation is faster than the regulation. So you see regulator always trying to catch up and often failing to do so. In Pakistani scenario की अगर हम बात करें तो at least from Sindh perspective से अगर मैं Sindh Health Commission की सेंस में देखूं, so सिलसिला ऐसा है कि they are more preoccupied with implementing some good standard in primary and tertiary healthcare, which is the need of time actually. Still 70% of the pre-corona days, 70%, 70 to 80%, in fact, more than 90% patient still shows in person to the doctor actually. And that's where the quality of healthcare is very, very important. So they are preoccupied in a pre-digital age, healthcare quality challenges. Most of their policy framework still based on that. And that is such a sizable homework for them. For them, digital health regulation seems a bit of a far stretch actually, right? They want to work on it, right? So also there is a decision that needs to take place because US में बहुत सारी जो ये मेडिकल डिवाइस के कैटेगरी में आती है डिजिटल हेल्थ रेगुलेटरी, सो वो FDA के पास चला जाता है, राइट? तो सिंध हेल्थ, सो यहाँ पे ये ड्रैप के पास चला जाएगा, ड्रग रेगुलेटरी अथॉरिटी ऑफ पाकिस्तान रादर देन सिंध हेल्थ कमीशन. ये डिबेट्स भी अभी ओपन है एक्चुअली, टू बी वेरी ऑनेस्ट. मैं कंज्यूमर के सेंस में अगर बात करना चाहूँ तो पाकिस्तानी कंज्यूमर लार्जली थोड़ा मुसीबत का ज्यादा मारा है इन टर्म्स ऑफ तबीयत के सेंस में. He want to be seen by the doctor. He does not much care about the data confidentiality and privacy actually, right? हम सब ने ज़ियाउद्दीन में काम किया है अपने अपने हाउस जॉब के टाइम पे. We have seen patients attendants seeing actually patient file, right? Back in those days, right? So privacy और उसके साथ साथ हमारे पास generally consumer level पे, healthcare consumer level पे awareness अभी भी काफी poor है, right? So और healthcare चूंकि regulated नहीं है, राइट? सो उसमें उसको लेके अभी तक जो देखा जाए कि काफी लूप होल्स हैं इसको लेके, राइट? सो रेगुलेटर का भी बहुत, सो इस हिसाब से पेशेंट आर एट रिस्क एक्चुअली, राइट? आई सीन अ लॉट ऑफ दीज फिजिशियंस एक्चुअली गिविंग कंसल्टेशन ओवर व्हाट्सएप, राइट? So that's Skype actually on phone. Yes, that also takes place even pre-corona days. हम सब डॉक्टर हैं, हम सब के रिश्तेदारों की कॉल आती है फोन पे कि तबीयत खराब है, क्या करना है, you know what I mean? ठीक है? And that takes place on
तो भाई इतने ज्यादा, मतलब आपको व्हाट्सएप के ऊपर, ये फेसबुक के ऊपर आपको इनबॉक्स मैसेजेस आ रहे होते हैं, ये पिक्चर्स दिखा के प्लीज टेल मी द ट्रीटमेंट ऑफ दिस. There can be 100 reasons of that particular problem, but वो नहीं, वो उसी वक्त they need. If you ask them, even it's like a little different from उनके point of view से. वो लोग आपको चाह रहे होते हैं यहीं पर दिखाते हैं और हम लोग उनको कहते हैं कि नीचे क्लिनिक आके दिखाते हैं because we have to examine and we have to run some tests or something. But
मेरे ख्याल से वो आप rather than asking the treatment directly, जो आपके रिश्तेदार या दोस्त कॉल करते हैं वो अपनी गूगल नॉलेज को कंफर्मेशन के लिए कॉल कर रहे हो and to learn from you and then go to their doctors. I have a very connected observation while we were just talking to you, especially Pakistan ke liye, and I think I want to have comment from Sadaf and Iffat and all of you, that don't you think that switching to losing the human connection in examining and treating the patient, जो आपकी क्वैकरी है वो उसकी एकदम हकीम आपके जाग जाएंगे होम्योपैथिक आपके पाकिस्तान में, and the non-traditional the medicine will take advantage of that, people who are readily available to be seen in person,
मैं आपको बताऊं, it's a very nice question. इंटरेस्टिंगली जिस तरीके से अभी इफ़त बोल रही थी, कामरान भाई ने बोला कि पाकिस्तान में ना, और हर जगह पे, खाली पाकिस्तान की बात नहीं है, पॉपुलेशन जो होती है ना उसके 2-3 डिफरेंट, आप उसको सेक्टर्स में डिवाइड कर सकते हैं, ठीक है ना। एक तो बहुत लर्नेड होती है, एक बीच में, एक वो जो कि बिल्कुल एट द लोअर एंड ऑफ नॉट ओनली पॉवर्टी बट नॉलेज एज वेल। वो जो है जो कि बिल्कुल लोअर एंड पे है पॉवर्टी और नॉलेज के, वो पहले भी हकीम के पास जा रहे थे और अब भी हकीम के पास जाएंगे, ठीक है। और अगर वो कभी डॉक्टर के पास जाएंगे भी तो उसकी एक्सपेक्टेशन ये नहीं होगी कि डॉक्टर मुझे ऐसी दवाई दे जिससे मुझे फायदा हो, उसकी एक्सपेक्टेशन ये होगी कि डॉक्टर मुझे ऐसी दवाई दे जो कि मेरे सिम्टम को ट्रीट करे, डिजीज को नहीं। ये भी मैं आपको बता दूं। और अगर आपका उस पेशेंट का सिम्टम सही नहीं होगा ना, तो वो फिर आपके पास दोबारा कभी भी नहीं आएंगे। ये आप लिख के ले लें। हद तक कि मुझे पाकिस्तान में प्रैक्टिस छोड़े हुए भी कुछ 2007 के बाद मैंने नहीं किया प्रैक्टिस, लेकिन ये मुझे अभी भी उतना ही ट्रॉमेटाइजिंगली याद है जितना कि पहले याद था कि ये दे आर नॉट गोना कम बैक टू यू इफ देयर सिम्पटम इज नॉट फिक्स्ड। आप भले से बहुत मेहनत कर लें, आप हाइपरटेंशन की कहानी सुना दें, आप उनको नमक के बारे में बता दें, कुछ भी कर लें, लेकिन दे आर नॉट गोना कम बैक। नाउ अब एक वो पॉपुलेशन है जो कि बीच में, ठीक है ना, वो पॉपुलेशन जो है वो डिजिटल हेल्थ को यूटिलाइज करेगी और कर रही है, इसलिए क्योंकि मैं 2-3 ग्रुप से ऐसे एफिलिएटेड हूँ जिनके साथ मैंने अपने एक्सपीरियंस के लिए काम किया, और एक ग्रुप मुझे बहुत पसंद आया जिसका मैं गुज़श्ता 6 साल से अभी भी हूँ, जो कि हेल्थ टैब के अलावा है, वो इंडिया का बेस्ड है और अमेजिंग ग्रुप। उसने बहुत स्क्रैच से शुरू किया और बहुत ज़बरदस्त। उसमें लोग, आपको पता है, पाकिस्तान से मैसेजेस करते हैं और बहुत सारे लोग हैं, और क्वेश्चन है और वो फ्री करता है, जैसे आप लोग चैट बॉक्स की बात कर रहे थे, समथिंग लाइक दैट, और वो बहुत अच्छा है। आप रिप्लाई करते हैं, बात करते हैं। वो इनिशियली कुछ क्वेरीज फ्री होती हैं पेशेंट के लिए, और बाद में जो है ना वो कुछ पेमेंट उसके लिए उसके ऊपर डाल देते हैं, डिपेंडिंग अपॉन वो किस डॉक्टर से कौन बात करना चाह रहा है, ठीक है। फिर उसके बाद जब थोड़ा सा और आप हायर क्लास की बात करते हैं, वो है जो कि डायरेक्टली कॉन्टैक्ट करेगा डॉक्टर से वीडियो। तो ये लोग टाइम नहीं वेस्ट करेंगे चैट करने की और पिकअप करने की, दे आर डायरेक्टली गोना कनेक्टेड विद द फिजिशियन, दे गो फ्रॉम देयर। और मैं आपको बताऊं, आजकल में ज्यादातर यही लोग होंगे जो कि डिजिटल सर्विस को यूटिलाइज कर रहे हैं, और ये दे विल स्टिक टू द डिजिटल सर्विस। आप देख लीजिएगा अपने प्राइवेट प्रैक्टिसेस में, दे आर गोना स्टिक विद यू गाइस एंड दे विल यूटिलाइज द डिजिटल सर्विस। लेकिन द थिंग इज दैट कि देखो, कुछ चीजों के लिए डिजिटल सर्विसेज प्रॉब्लम नॉट गोना हेल्प। लाइक फॉर एग्जांपल, अगर आप स्क्वामस सेल कार्सिनोमा के बारे में सोच रहे हैं, you're not going to look at, maybe it looks like squamous cell carcinoma, but you need to have a biopsy. That's how you're going to confirm, right? अब अगर वो लोग जो है वो आपके कहने पे, यार आपने एक विजिट किया वीडियो और आपने कहा कि यार देखो ये मुझे सस्पिशियस लग रहा है और मुझे उसकी बायोप्सी करनी है, वो अब क्वैक के पास जा रहे हैं क्योंकि स्पेशलिस्ट ने बोल दिया कि यार ये कैंसर हो सकता है, तो आप उस मेंटालिटी के साथ कुछ नहीं कर सकते। और वो हर जगह पे यही रहेगी, इट डजंट मैटर कि आप कौन सी कंट्री की बात कर, ये भी मैं आपको बता दूं। और देसी जो होते हैं, अनफॉर्चुनेटली, वो अमेरिका में हो, पाकिस्तान में हो, इंग्लैंड में हो, कीनिया में हो, वो देसी हो। ये भी मैं आपको बता दूं। ये भी आप लिख लें और कहीं पे ना उस पर स्टैंप लगा के ना रख दें, क्योंकि यहाँ पे भी जब मैं पेशेंट पॉपुलेशन डील करती हूँ तो मुझे एक डिफरेंट मास्क पहनना पड़ता है जब मेरे पास देसी पेशेंट्स आते हैं, क्योंकि वो अप्रोच ही डिफरेंट होता है उनके साथ। You just cannot deal them equally because it's the care is the same, the recommendations are the same, the medications are the same, but the way you have to convince them is entirely different. It's just a mindset. You just cannot change it. I don't know what's your experience been.
So I think with our experience of working in the communities, जब हम क्लिनिक लॉन्च करते हैं तो हमारा सबसे बड़ा कंपेटिटर ही वो क्वैक या वो फेथ हीलर होता है जिस कम्युनिटी में है। बिकॉज हम 50 रुपीज़ में उन्हें एक ऑनलाइन क्वालिफाइड MBBS डॉक्टर से कनेक्ट कर रहे हैं और वो अगली गली में 30 रुपीज़ लेके ही हैज़ द क्योर फॉर एवरीथिंग एंड ही इज जस्ट प्रिस्क्राइबिंग स्टेरॉइड्स एंड दे थिंक कि सिम्टम्स सही हो गए हैं तो बस। बट हमें बड़ा काम करना पड़ा इस पे कम्युनिटीज़ में, ख़ास तौर पे इन टर्म्स ऑफ एजुकेटिंग पीपल, पर्टिकुलरली द वुमेन। So in our community model, what we do is that with every clinic that we launch, we recruit a female mobilizer, and her essential role is to go door to door, उसने कुछ नहीं करना आपको, लोगों के घर में जाके उनके साथ ज़मीन पे बैठ के उन्हें डेमो कराना है कि देखिए ये एक ऑनलाइन डॉक्टर है, या आप इससे इस तरह लैपटॉप पे बात करेंगे, ये शहर में बैठी डॉक्टर है. सो यू नो हाउ दे सेल इट टू देयर कम्युनिटी पीपल कि देखिए ये तो कराची में बैठी हुई डॉक्टर है, या आगा खान की ग्रेजुएट डॉक्टर है, या ज़ियाउद्दीन की. एंड दैट्स व्हाट दे हैव टू बिल्ड ऑन. एंड वेरी राइटली सेड, हमें इनिशियली एक और बड़ा चैलेंज ये होता था कि वो जो भी आते थे पेशेंट्स क्लिनिक में, वो कहते थे यार आपकी ऑनलाइन डॉक्टर तो ड्रिप ही नहीं लगाती, ये इसने तो बस 15 मिनट बात की और इसने ये कह दी, इसने ड्रिप ही नहीं लगाई, ये कैसे होगा. सो आई थिंक वहाँ पे ना वो बड़ा एलिमेंट हो जाता है कि डॉक्टर को अपनी रेपो बड़ी स्ट्रांगली बिल्ड करनी पड़ती है उस नर्स से जो उस क्लिनिक को एसेंशियली लीड कर रही है, और फिर हर पेशेंट से. एंड इट टेक्स टाइम. सो हम जब एक क्लिनिक लॉन्च करते हैं, यूजुअली व्हाट वी आइडियली वांट इज कि एक क्लिनिक अपने यूनिट इंफ्रास्ट्रक्चर पे एटलीस्ट 12 to 18 मंथ्स में अपने काइंड ऑफ पैरों पे खड़ा हो जाए. So it actually takes 12 to 18 months for a clinic to really be able to reach that point कि इतनी clientele आपकी बन जाए कि ना सिर्फ clinic sustainable हो जाए, but people start recognizing those online doctors. But ये होता है. और अब ये situation होती है कि because we have alhamdulillah 26 clinics all across Pakistan in 3 provinces excluding Balochistan. और अगर कोरोना नहीं हुआ था तो we were about to open our 27th clinic in Balochistan also. But अब ये होता है कि after every 2 months we change the rota of doctors, and actually patients come in saying कि यार वो जो for example डॉक्टर हिना थी, वो जो डॉक्टर बीनेश थी, उन्हीं से बात करनी है. And we have to like the nurse has to counsel them कि भाई रोटा चेंज हो गया, अभी डॉक्टर वो वाली नहीं है, अभी ये है. But then वो रेपो बन जाती है, थोड़ा टाइम लगता है, but I think बन जाती है. यहाँ पे
So how did you experience के जब educate कर रहे होते हैं, how receptive are people, and especially that group, the socio-economic group, how receptive
so
are
you
they?
have to just go to their level. वही उनके साथ चटाई पे बैठ के उनको लैपटॉप पे स्क्रीन पे दिखाना कि देखो ये डॉक्टर है, इससे बात करनी है. So you have to go to that level to be able to make them understand. 2018 में पाकिस्तानी डेमोग्राफिक सर्वे हुआ था, and it's a very sad stat, and I thought क्योंकि हम इस बारे में बात कर रहे हैं तो let me quote it here. It says that 75% of the Pakistani population does not go to an authentic doctor. So they might be going to a quack, a faith healer, a homeopath, a hakim, but they're not going to an MBBS doctor. So that number is alarming. Again, I think government has to really start working on this, because I think there's only so much education that initiatives like us can do.
And Kamran, you also had an experience with SINA organization when you were working in the squatter settlement in Karachi. So you know, it's a really dilemma when quacks are more reachable to community at a primary healthcare level than an MBBS doctor. So your comments on that?
Yeah, so I'll add to what Iffat just mentioned, actually. So a bit of a history about SINA. So SINA is a not-for-profit primary healthcare organization. They've got 30 clinics. I had an opportunity to work there as a chief operating officer for 3 years. So they have 500 people, 100 plus doctors, through 250 plus nursing staff. They treat 1 million patients in a year, right? Round about 3,000 to 4,000 patients in every month. And we were lucky enough to kind of create our own Android-based EMR and create a paperless environment. All of these clinics are situated in a deep urban slum, actually, in Karachi. So Karachi ka jo 60% है वो actually urban slum है, as a matter of fact, right? और उसके deep into urban slum. So होता ये है कि actually majority patients जो हैं देखें जो जितने पाकिस्तान में अभी भी मेजॉरिटी केस में जो फैमिली का जो स्ट्रक्चर है ना, काफी न्यूक्लियर किस्म का है. जैसे मेल टिपिकल हेड ऑफ हाउस होल्ड होता है और ही कंट्रोल्स द फाइनेंशियल एंड ट्रांसपोर्टेशन मींस, व्हिच मींस दैट सबसे ज्यादा इफेक्ट होते हैं बच्चे और खवातीन एक्चुअली, क्योंकि वो जब अगर वो काम पे गया है तो ना वो औरत क्लिनिक जा सकती है, उसका बच्चा बीमार है, जब तक वो घर नहीं आएगा, ठीक है, वो ट्रीट नहीं हो सकता. पैसे का भी फाइनेंशियल कंट्रोल उसके पास है कि वो पैसे देगा तो ट्रीटमेंट होगा, ठीक है. नाउ दिस इज व्हाट रियली हैपेंस. सो अच्छा, चूंकि मोहल्ले का जो क्वैक होता है, राइट, वो ही इज अ वेरी गुड सेल्समैन एक्चुअली, राइट, बिकॉज रेशनैलिटी से कोई ताल्लुक नहीं है उस चीज का, उसका emotions से ताल्लुक है, right? And he's able to convince them. And also he looks like one of them, as a matter of fact, right? ठीक है? They go for the quick fix, actually, was steroid based, multi-bionta, and I've also seen putting hormones into drips, as a matter of fact, and you name it, it's mad, right? So when we created Sena Clinic, so we first started with a cost structure which is in competition with those quack. So people, when they are making choices, so they would come to our clinic rather than going to the quack, right? So they get a good physical environment through proper environment with a proper trained doctor, जिसका clinical effectiveness का test भी होता है, उनका OSCE भी होती है actually, which is a very tough OSCE that we used to do, still do, right? So through proper, जब वो जाते हैं वहाँ पे, और फिर वो जब वापस क्वैक के पास जाते हैं, वो बोलते हैं यार तुम्हें जितने पैसे देता हूँ और उतने में मैं सिना में अपना फ्री इलाज कर लेता हूँ, मुझे इंसुलिन भी मिल जाती है, तो मुझे दवाइयाँ भी मिल जाती हैं 50-60 रुपए में. अब वो ऑब्वियसली एक्चुअल कॉस्ट तो बहुत ज़्यादा पड़ती है, 450 to 500 रुपीज़ पर पेशेंट पर विजिट पड़ती है, बट वो क्रॉस सब्सिडाइज करके को पेशेंट कोऑपरेट करता है 20 से 50 रुपये डिपेंडिंग अपॉन द अफोर्डेबिलिटी लेवल. और तो वो एक सोशल अकाउंटेबिलिटी बिल्ड हो जाती है. तो जाके क्वैक को सुनाता है कि ये जब इतना अच्छा क्लिनिक चला सकते हैं, राइट, इतने कम पैसों में मुझे दवा दे सकते हो, तुम क्यों नहीं कर सकते? सो आहिस्ता आहिस्ता वो वॉर जो है सोशल अकाउंटेबिलिटी के सेंस में थोड़ी मिलती है. तो इट विल टेक जनरेशन फॉर दैट ओवरकम. ऑल्सो क्वैकरी के बारे में मेरी ओपिनियन थोड़ी सी मुख्तलिफ है इसको लेके. जितने क्वैक्स हैं दे ऑल वांना बी डॉक्टर्स, राइट? इन सबको रिहैबिलिटेशन की जरूरत है रादर देन इनको जेलों में डालने के बजाय. There is a need for the training program which has to be incentive based, right? So for them to act as physician assistant, they need to get trained, right, and sent back to the community actually, right? You would have a good human resource available who can train people on ground. What you need is a good third party monitoring actually, very good eyesight into the clinical record through digital health and paperless based system where the records get entered into a digital database which government can monitor over the period of time about the clinical effectiveness of that physician. That can control a lot of things, right, rather than putting them on the jail, right? So they need to rehab actually. That's what I believe. With a good incentive structure they can rehab. They would really do a good service. They have a better enrolled that, वो ऐसी बात है कि एक off the cuff example दूं. दूध जो हम लोग इस्तेमाल करते हैं घरों में, एक पैक मिल्क होता है, एक जो गवाला आता है, राइट? इसी तरह की एग्जांपल है, ठीक है? वो जो डॉक्टर है पढ़ा लिखा, वो एक पैक मिल्क वाला सीन है, और वो जो क्वैक है वो गवाला है बेसिकली. आई मीन लाइक इट्स अ क्रूड एग्जांपल टू गिव, मगर वो जो गवाला की जो कल्चरल इंपॉर्टेंस है ना, वो 80% है अभी भी, अनफॉर्चुनेटली, राइट? पीपल आर कंज्यूमिंग दैट डर्टी अनफिल्टर्ड मिल्क, 80% of them. It's 20% packed milk market, right? ठीक है? So if you really want to correct the system, अब सारे गवालों को अगर आप जेल में डाल देंगे तो वो 20% क्या तीर मार लेंगे भाई, ठीक है? उससे बेहतर ये है कि जो एग्जिस्टिंग सप्लाई चेन है हेल्थ केयर की, उसको आप अच्छी तरीके से क्वालिटी एश्योरेंस कर ले. You would end up in a better system. That's what I feel. Yeah, that's my opinion. Yeah.
I think absolutely. Yes. Just a small comment on what Dr. Kamran is saying. जो एक कम्युनिटी में लेडी हेल्थ वर्कर बैठी है, अगर उसकी आप स्ट्रगल्स देखें ना, तो शी इज ऑल्सो अ हीरो इन हर ओन वे. But she has fought all of those conservative barriers, patriarchy in her community to be where she is today. So I think Dr. Kamran, because he was just spot on with this. Instead of eliminating them, they really need to be attached to, for example, online doctors, so that their credibility is built, their practice is actually built over time. And I think this all needs to be authorized and approved by the government. Because Pakistan में लेडी हेल्थ वर्कर्स, कम्युनिटी हेल्थ वर्कर्स और मिडवाइफ्स का एक बड़ा स्ट्रॉन्ग इंफ्रास्ट्रक्चर है, और ये वो खवातीन हैं जो अपने अपने गांव की हीरो हैं, क्योंकि ये ऐसे गाँवों में बैठी हैं जहाँ घंटों तक कोई डॉक्टर अवेलेबल ही नहीं है. फॉर एग्जाम्पल, एक हमारा क्लिनिक एक इलाका है जो हैदराबाद से आगे है, वहाँ होता था. एक हमारा क्लिनिक है जो मचका में है, विच इज़ एट 2 hours फ्रॉम रहीम यार खान. So can you imagine 2 घंटे की दूरी तक ना उनके पास कोई लैब का एक्सेस है, ना उनके पास कोई अल्ट्रासाउंड एक्सपर्ट का एक्सेस है. तो वहाँ पे जो लेडी हेल्थ वर्कर बैठी हुई है, शी इज द प्राइम ऑप्शन दैट कम्युनिटी हैज. So
And imagine removing that person from the equation. When the doctor जो graduate करता है ना किसी गांव से, उसके पास incentive होता है उस गांव से move होने का, शहर की तरफ जाने का. He has no incentive to stay back in his village actually, because for an ROI he will move to the urban place. That's one thing. I just want to quickly add here. Let me give you a quick example here. I was working with the Aga Khan Health Service. So Aga Khan Health Service is the primary healthcare arms of Aga Khan का जो healthcare system है. So I was lucky enough to be a part of that organization. I visited a number of places. So एक मीरपुर साकरो के करीब एक इन्होंने बहुत जबरदस्त हॉस्पिटल बनाया. वहाँ पे सिजेरियन सेक्शन डिलीवरी और नॉर्मल डिलीवरी वगैरह. But it was very interesting to see women was not turning over there because it was state of the art. Like Aga Khan jab kaam karte through proper kaam karte hain wo log, right? So they create a good hospital like with obs and gynae, like surgeon coming there every week doing surgeries. Magar volume built nahi hua, utilization was poor. What really happened was कि local जो दाई थी ना, उसकी पूरे गांव के साथ क्रेडिट लाइन सेट हुई हुई थी. वो क्रॉप साइकिल के तहत उधार पे डिलीवरी करवा लेती थी, ठीक है, और उसके बदले पैसे नहीं लेती थी. वो रल्ली, मटका, चाय के कप या इस तरह की चीजें, बार्टर सिस्टम चल रहा होता था गांव में, और उसको क्रॉप साइकिल का पता था. जब क्रॉप साइकिल डाउन होता था वो क्रेडिट लाइन चलती थी. जैसे क्रॉप साइकिल अच्छा होता था, पीपल यूज्ड टू पे हर बैक. नाउ दिस इज अ फाइनेंशियल मॉडल which institution like Aga Khan couldn't fathom. As a matter of fact, the utilization was locally was poor. So in order to do the local change, one has to really break into the local model, right? So बेहतरीन idea hospital बनाने की वजह ये होता कि उन दाई को trained birth attendant बनाए, फिर उनके पास physician assistant या nursing की कोई ऐसी local degree लेकर आए कि वो वहाँ पे अपने ही model पे काम करें और health care system को improve करें, right? So replacement does not always work, especially in a lower middle income country like Pakistan. कराची के सारे quacks को हटा देना तो कराची का हेल्थ केयर सिस्टम नीचे चला जाएगा एक्चुअली, right? I'm not saying that they are doing a good practice. They're doing a very criminal bad practice, but they need to rehab, right? Rather than removing them off that, they need to get improved. That's where the regulation should be. Regulation needs to be empathetic of people's need rather than isolate the healthcare system overall, right, in terms of quality.
Yeah. So I want to have some quick comment from Dr. Sadaf related to her specialization. Obesity in COVID-19 and post-COVID-19, we're all going through that phase.
Yeah. So very interesting question.
Yeah.
So I will start off by saying that this pandemic was present before the COVID-19. So COVID-19 pandemic followed the obesity pandemic.
देखिए ये वो दुनिया का वो कर्व है जिसको काफी अर्से पहले फ्लैट हो जाना चाहिए था, मगर ये वो कर्व है जो
फहद ने लिखा ना, I'm trying to stay away, I'm social distancing my fridge from my fridge to flatten my curve. So yeah, obesity is actually a very strong risk factor. Hopkins, I think 4 or 5 days ago, they actually published their data showing that young people, both males and females, were at high risk of having more complications if their BMI was more than 29.9. Or interestingly, हमारी Asian population में तो if the BMI is more than 27, you are characterized as obese. So ये एक important बात है that we need to keep in mind. However, everybody who is practicing telemedicine, I would want them to really remember that once you start doing telemedicine, you will forget yourself because you are sitting on the chair from dawn till dusk, and आपको जो है ना बिल्कुल भी पता नहीं चलता. You just keep on eating and keep on watching. Thanks to Ramadan, that it's really helping for a month. But I hope that the laws will become a little bit more softened and things will improve. We will be able to see more people face to face. Lekin I love obesity medicine. It all started from my own journey, and the realization that I always used to think that I'm eating right and I'm really working out. But the fact that nothing was going on the scale made me think, why? And we have a very nice conference here in Maryland, and I actually took that. And Jesse conference, as it was progressing, I was like, OMG. सबसे पहले तो I know the wrong classification, because the Asian Pacific classification is the one that I should be using, because I'm Asian, not the one which is applied on Caucasian. So सबसे पहले तो I had this realization that I should fix my classification based on the BMI. The second thing was that I used to take an apple and a banana every afternoon in my lunch, and thinking that, oh my God, I'm having an apple and a banana, not knowing that I'm having 52 grams of carbs, whereas I'm allowed to have 120 in the 24 hours. So that was the second thing. COVID, yes, it is causing obesity in physicians. So we have to be careful about that. I would say, please eat right, have high protein diet, take good care of yourself, do exercise, don't forget yourself, because you are very important for yourself. You're important for your family. You are important for your patients, definitely. If you need any kind of information, recommendation, suggestion, please feel free to email. I will be always available to discuss anything related to outpatient medicine and management, related to obesity and weight. So high protein diet, not all the pakoras. You're already doing intermittent fasting though, but still,
Yeah.
you have to be careful about those pakoras.
So
Iffat,
it's a
can
bit,
you? Yeah.
yeah, Uday, you can ask.
Yeah, Iffat, I want you to elaborate on your Sehat Kahani government partnership with Digital Pakistan and Yarane Watan platform.
So I think I spoke briefly about the Digital Pakistan partnership.
Yeah. Yeah.
So they're facilitating us in marketing this and really enabling us to get the exposure so that more and more people can avail this service. Also, when we screen people for COVID-19, the idea is that if there are people who are suspected to be positive, then the government can track them. So it's kind of like a tracking mechanism that we have in place with them. So that's what we're doing with them. With Yarane Watan, that's also a very interesting initiative. We are getting volunteer doctors from the diaspora, from US, UK, and this is an opportunity open for everyone. And what we are trying to engage with them is that they can join our platform and they can volunteer and give back to Pakistan. It's a volunteering opportunity for all of those Pakistani doctors based in the diaspora who want to give back in this time. Because while we do have a lot of general physicians, Pakistan has a huge shortage of specialists. If I talk about psychiatrists and psychologists, for a population of 200 million people, we only have 400 psychiatrists. So, it's insane.
Yeah.
So the idea is that all of those doctors who can take out few hours from their everyday routine can join this network and give back. And I think in the chat somewhere, I mentioned the link where they can go and also apply, start sending in their resume so that people can join in. So this is essentially the initiative that we have.
And how many patients have you seen in the current lockdown, and how many were the COVID suspects? Do you have a number?
So we've seen around 15 to 16,000 patients collectively. Around 15% of them were suspected to be COVID, who were then obviously educated for home quarantine, or if they were severe, then they were referred and then they were followed.
But they were tested. Were they tested, and how many were confirmed COVID patients? Do you have any record for that? Or?
So they were around total to suspect patients, say around 350 plus. Not all of them did get screened, but out of the ones who did got screened last week, 2 of them were reported positive. So this is the idea. See, I think our job is to make sure that they are referred, they're triaged, they're like pushed through our call center and the frequent follow-ups that whether they went for the screening or not. But unfortunately, एक बड़ा मसला पाकिस्तान में होता है कि not everyone's taking it that seriously, and many people
Yes.
have अच्छा ठीक हो
But
गया
do
बस.
you inform the authorities or?
Yes, we do. So then they also follow them up, and we also follow them up. जैसे बहुत सारे ऐसे हैं जो screen हुए और negative भी आए, but two of them were positive.
Yeah. Dr. Sadaf, we have a question about what do you think of keto diet?
It's a very famous question. So in Ramadan, I will say, please don't induce ketosis because you're already in intermittent fasting. So see, they both are two different type of diets. And as you know, it's like your total daily intake of carbohydrate is less than, it's about 20 grams. Some people will go into ketosis when they start going less than 50 grams. Keto strips are already available in Pakistan, and you can actually test your urine and check as you go in ketosis. I would not recommend doing it in Ramadan. You can always do it once the Ramadan is over. Yes, it causes faster weight loss, but I have been always explaining this to people that this is a short and robust diet. It is not a lifestyle. So once you have achieved your weight loss goal, you may have to introduce carbohydrates back slowly, little by little at a time, and then go to your maintenance carbohydrates and then stay there. Because doing ketogenic diet for long term, A, is very difficult, B, can have a lot of side effects. Usually keto diet should be supervised by a physician, but apparently in Pakistan people are doing it all by themselves, although having a lot of complications like hyperuricemia, hair loss, thyroid problems, electrolyte disturbances, cardiac issues. So if you have somebody who can actually supervise you, that would be the best thing to do. But again, not in Ramadan. Perhaps you can reduce the amount of carbohydrate you are taking. Really, I'll just give you an example. देखिए चोला चाट जो होता है, सिर्फ अगर आप चोले को ले लें तो आधा कप चोला जो होता है इसमें ऑलरेडी 60 grams होता है. And this is more than in half cup of potatoes. So you're already, you're over your limit. So you can reduce the amount of carbohydrate, not necessarily going into ketosis. You can select that, like a normal person is supposed to do 120, you can select 80 and just go by 80 and see how you do if you restrict yourself to 80 grams per day. That's not going to put you in ketosis, but at least your Ramzan will be fine.
You don't really discourage it. I mean, there are a lot of.
I don't discourage it, but I don't encourage it in Ramadan because you're already doing kind of intermittent fasting in
Ramadan, but you don't generally discourage it because there was a question somebody posted to me to talk to a nutritionist, and the nutritionist totally said that you are not supposed to do these fat diets, and this is one of those.
Yeah, and that is
not
because,
going to be good.
Yeah, sorry, I'm interrupting. I'm assuming that the person is completely normal and has no underlying medical conditions. If somebody has an underlying medical conditions like rheumatoid arthritis, or as I just saw, psoriatic arthritis, or has gout or thyroid disorder or others, then I would say it's better to do low carb, as I mentioned, over ketogenic diet. Ketogenic diet is usually better for people who do not have any much underlying disorders, or people going for, let's say, knee replacement, right? And they are like 300 pounds and they have to lose 100 pounds in 4 months or 6 months. And they really need to lose that weight. Otherwise, you cannot give them anesthesia. So there are set guidelines. Maybe we can talk about the obesity in grade.
Yeah, we can, because it's a huge topic in itself. Yeah. Because one of my patients, she told me, she was asking me for advice about, because she had PCOS, and I have heard that in PCO the best diet that works for you is ketogenic diet. Is it true?
Not necessarily. Not necessarily. It's basically, as I mentioned again, the way we divide these diets is based on the amount of daily intake of carbohydrates.
Yeah.
It's like very low, and so forth. And then it depends how much carbohydrate your patient was taking at baseline, and then how much calories your patient is taking at baseline, and then how much proteins your patient is taking at baseline. So, it depends on the underlying medical conditions and how you can design the diet for the patient. So, but not necessarily. No, I would say no. You can just do, as I said, you can just do low carbohydrate. You really don't have to put the patient in ketosis to give them for PCOS, and it can be same for fertility. Like I have patients, they just lose. I just put them on low carbohydrate diet. Like I just make them 80 grams. They just lose
Yeah.
20-25 pounds, and they are able to conceive. Yeah.
I
Sorry.
think I can definitely get in touch with Dr. Sadaf because I actually lost 20 kgs in the last few months because I went. I did.
You look small. Actually, I was looking at you. I was like, oh my god, ki choti ho gayi hai.
So I did keto diet, but then I had a bad hair fall. Like
That's what I'm saying. That's one of the side effects. So you may have to, reintroduce carbs slowly and gradually back. And we can talk about this offline, but you need to do it slowly and gradually. Yeah.
I think we can do a session with you separately
Oh.
after the COVID thing is over. We can
Yeah,
do a proper with you. Yeah.
absolutely. Not a problem.
We'll have some charge session of post this.
Yeah.
These.
Yeah, and it's going to be a pretty popular session. Don't worry.
Especially in COVID time when everyone is at home. Right?
वो obesity को curb करने के लिए बाद में session
Exactly. We all are eating and just sitting at home. So yeah. And pakoda, samosa in Ramadan, you know how it is. Yeah.
Iffat, we have a question. What screening tool do you follow? So, Iffat, would you like to answer that?
So for regular patients, it's an entire patient history form that is embedded within the app, and it's on the patient's discretion. Ideally, we recommend the patient to fill it out entirely. So it has all the questions जो हम history में पढ़ते थे, including social history, family history, past medical history, any allergic, any vaccinations done in the past, current medications, all of that. But for the COVID patients, we are following the questionnaire that has been released by that is a part of the national guidelines for COVID screening and COVID treatment. So for that, entirely we're using that as a tool to identify and screen them through the questionnaire, because उसका history थोड़ी सी different है, because उसमें बहुत ज़्यादा travel history पे focus है, exposure पे focus है, symptoms पे बहुत focus है, because again जब हम telemedicine कर रहे होते हैं तो a lot of the history has to talk about the patient's symptoms, so उसमें ये सारी चीज़ें शामिल हैं. फिर अगर पेशेंट को रेफर करने की ज़रूरत पड़ती है तो दैट्स ऑल्सो अ टेम्पलेट प्रोवाइडेड बाय द नेशनल गाइडलाइंस, सो दैट्स एसेंशियली व्हाट वी आर यूजिंग.
Okay, we're almost at the end of the session, and I'd like to open the platform for before we have some final interesting words from Kamran on COVID-19 in general. I want to ask if any of the guests would like to ask questions from each other. Like, if you have any question for Dr. Sadaf on telemedicine or vice versa, you're open to.
I think more. So I think I have two questions. The first question is, where do you see this pandemic going? Where are we standing, and what's going to happen? And the second question, again, we can take offline, is that I'd really like to learn the legal infrastructure of how telemedicine is working in the US. So it would be a great opportunity for me to be able to get in touch with you and discuss this offline.
Yeah,
and understand the legal infrastructure.
Yeah, sure. So first of all, I really want to compliment the hard work that you're doing and the way you have connected, I would say, the dots together. I think it's a dream work. If somebody would ask me, if you would want to do something else, what would you do? I would say it's exactly what you have done. So I cannot say enough. It's an excellent job, both to Kamran and to Iffat. It's amazing. So excellent job, excellent job.
Thank you.
Now, now where the COVID-19 is going, it's a very good question. I wish I can tell you where it is going. I think no one knows where it is going, but it seems like
Yeah.
it's probably gonna plateau a little bit. We may see things coming down. I think it will become a second norm for people. And my feeling is that people will start seeing it as the second flu, like an influenza, and would expect it for at least the next 2 years that it will come back and go. However, we may see a little bit higher mortality if we do have a second peak. That is all my fear is. In Maryland here, for the last 3 days, we had excellent numbers. Actually, we were doing good, and then suddenly today, our numbers went up. So it's really unpredictable. Every state has been given certain rules, but we have to plateau for at least 2 weeks before we are allowed to open up completely in a phased system. And some states have opened up, like Georgia, for example. So um, I think we have to continue doing the social distancing. That will be a new norm for everybody. Unfortunately, I don't see for us that the schools will open anytime soon. I think the kids will be going back. Here, the schools open like in September, so I'm thinking that's probably what's going to happen. And even then, we will be afraid every time they sneeze because we will not be sure what's going on. And the most confusing thing would be when influenza will be coming in the fall, because it's going to be a big problem.
Yeah.
Then you really don't know what's going on, because but I'm hoping that by that time we will have the kits available where you can not only get tested at home, but we will be able to do it in the offices, because right now we don't have it in the office. We have to send our patients to the tents. So I fear for people who are immunocompromised, to be honest, because there the mortality is double than the mortality what we see in the general population. Like there was one study where it was like close to 40%. That is what really my main concern is, because we do see elderly, we do see people who are immunocompromised, and we do see people who are frail. But we have to take it with a grain of salt. We have to protect ourselves, our staff, and our surroundings. And once again, I will say all the physicians need to really take good care of their own selves, because we are not only responsible for ourselves, we're responsible for our families as well at the same time. So, I mean, that's all I have to say.
Kamran, you have any questions to other panelists?
Well, I don't have a question, but I have a comment here. As you just asked about the question that you asked, what are my views about the COVID-19 as such? So I just want to say, overall, viruses existed before us, before the humanity exists, and likely they are going to exist after us as well, given the history and resilience and ability to mutate, right? A lot has been discussed with respect to clinical aspect of viruses, especially coronavirus. But I want to migrate a bit from that. I would take a different angle to viruses here. So virus, if you look at the human evolutionary history, अभी जो recent research जो मैं पढ़ रहा हूँ, उसके तहत अगर देखा जाए तो viruses have been playing a very key role in human development, especially the human genetic makeup की मैं बात कर रहा हूँ, right? अभी जो recent studies आ रही है उसका अभी we have a common Darwin की theory है ना about human evolution, right? Survival of the fittest, stuff like that. मगर उसमें एक बहुत बड़ा context missing है, which is zoonosis and viral infections actually. If you factor in इंसान का जो memory की capability है, इंसान की जो cognition की capability है, it's gifted by viruses, right? There is a recent discovery that has taken place in which they have discovered this ARC protein, in which is a very critical component in a proper functioning of human memory, right? So our protein कैसे travel करती है, वो capsid की form में travel करती है from one cell to another cell, just like viruses. It has a capsid-like structure like viruses, right? So इंसान की history में there was a viruses के जो पिछली generations थी millions of years back, right? So they infected humans and they left behind reverse transcriptase based DNA fragments which became part of the human DNA, right? When they transcribed, they created a capsid-like protein, which now work as an ARC protein, because of which we have memory, actually. Right? If you look at the human history, जो frontal cortex है, ये तो बहुत बाद में develop हुआ है. इससे पहले तो reptilian brain था, right? Mid brain, basically. So fear, fight, or flight was the mode, right? It's the only later part, much later, human cognition part, the frontal cortex, the cerebral cortex, functioning abstract thinking started taking place, right? So that event is also linked with big viral infection, which is left behind as DNA sequences, which became a part of our genetic makeup, which led to the human cognition, as a matter of fact, right? So viruses, while rightfully so demonized for infecting and killing a lot of people, they need to be looked into from an evolutionary course, scientific, anthropological and evolutionary course. So ये जो अभी pandemic आया है, it leaves behind part of its DNA into our system, which over the period of centuries is going to give us new set of proteins, actually, which is going to give us new set of physiological functions important for our survival. So in a long-term course, if you look at that, a long view अगर लेंगे, so बहुत सारी चीजें हमारी gifted by viruses हैं, actually, right? So it may be killing people right now. I'm not trying to underestimate the notoriety or virulence of pathogenicity of it. There's no understating that, but there's a other scientific element to it which we need to understand. What part of its DNA becomes part of our DNA structure, and when it encodes, what sort of protein it is going to contribute to our physiological or pathophysiological phenomena, right? So this needs to be looked into. So I'm seeing like coronavirus from that angle as well, and that we need to look into, right?
So interesting perspective. I think it was a great session to have all three of you in our session. And while ending this, we're gonna have a small ending note for you, to our listeners, to viewers, to alumni, and all the healthcare workers that are fighting this COVID. We're gonna have some future sessions too, and hopefully they will be without any COVID specific question. So to start with Kamran, Iffat, and then Sadaf, we can have ending comments from you.
So my comment is to especially हमारी जो physician community है उनके लिए और people in general. Coming from the last comment I made, survival of the fittest. So it is more like survival of the most adaptable. वो एक किसी की saying है कि in long term history, it is not the most genius of the species will have the highest of survival. It is the species which are most adaptable. It applies to us, all of the humans, especially physician, right? हम जितना जल्दी से टेक्नोलॉजी को अडॉप्ट करेंगे, जितना जल्दी से इस assumption को preempt करेंगे कि ये एक पहला पेंडेमिक नहीं है, ना ये आखिरी पेंडेमिक है, तो हमें कैसे अपने आप को सर्वाइव करके चलना है, स्पेशली व्हेन वी आर डूइंग अ फ्रंट लाइन वॉर, right, against this invisible enemy. The quicker we adapt, the better the survival, number one. क्योंकि डॉक्टर बनना is not only expensive, it takes years, right? बहुत सारी पेरेंट्स की एक्सपेक्टेशंस के साथ बनता है, और वही कोरोना से हमारे जो डॉक्टर्स आर नॉट बीइंग created to die treating infection. Actually, they are supposed to be living and treating all these illnesses, right? Okay, so there is no glory, by the way, right? Dying of infection, right? I mean, not having PPE and treating the disease. So वो जो किसी फौजी को आप उसके आर्म्स और एम्यूनिशन के बगैर अगर जंग में भेज दें तो मारा जाएगा, ठीक है? So जितने डॉक्टर्स आते हैं वो PPEs पहन के ही जाएं, उनके हॉस्पिटल्स अगर नहीं दे रहे हैं उनको, pressure them, really pressure them, There is no glory in fighting the war without ammunition, actually, right? And to adapt. For the common people, I think the best thing you can do is to unlearn and learn. This is the best time, right? Unlearn and learn. So that's what it is. Unlearn what you have been thinking will be the regular part of your life, and learn what you can do something new and adapt, right? Learning. My daughter is studying online, right? I never expected her. Okay, well, it's age made. She's like 6 years old, would be going online for her classes, as a matter of fact, right? You know, I for one attended online course like last year, right? And I did it like very, very casually, as a matter of fact. But it's the new norm, right? So adapt faster so that strategic relevance and survival stays there, right? You guys are doing a very, very important work, especially Dr. Azad. ठीक है, सो आपका जीना सबके लिए, सबकी जिंदगी के लिए अहम है, तो लिहाजा stay, keep yourself protected from this pandemic, right? Yeah.
I think, first of all, thank you to both of you for coming up with this amazing initiative. I think this was much needed. And मैं पहली talk से ही देख रही हूँ the amazing talent that Ziauddin has actually produced. The amazing kind of doctors, and कहाँ दुनिया में फैलते थे, they're doing such amazing things, और हमें शायद पता ही नहीं था. और अगर ये talks का सिलसिला ना शुरू होता तो शायद हम इतना connect ना कर पाते. तो I think this was very much needed. And COVID or no COVID, I would really request कि ये सिलसिला चलता रहे. There are tons of topics. I think एक तो आज ही discover हो गए keto diet. So I think we need to definitely continue this. Secondly, मैं फ़हीम की तरह मैं भी असल में, क्योंकि I'm a business woman, so please download the सेहत कहानी application, become our teacher. And for doctors, please apply as a doctor for the network that we have built. So वो कहते हैं ना, business persons जहाँ भी जाते हैं वो somehow अपना मंजिल बेचना शुरू हो जाते हैं. So that's what I do. But I think with this time, everyone is going to really understand the importance of digital health and digital media. And that's why we are here. We all are here to create the maximum noise for it. So just join hands with us in creating that noise. And thank you so much for watching this.
Dr. Sadaf?
You know what? I think we all are doing a very great job all over the world, not only as practicing physicians, but also as parents, as siblings, as kids, because these days there's a lot of anxiety going on. But despite of all that, we get up in the morning, we prepare ourselves, we go to work, or if we are working behind the scenes, we are making sure कि जो भी हमारे struggles हैं हम उसको एक तरफ रख के we just serve the population, we serve the people. But I also wanted to thank ZMU Alumni for coming up with this beautiful opportunity to connect us all. और बहुत ज़्यादा जब मैंने वो पहला सेशन देखा मुझे इतना अच्छा लगा, like I was working, मैं बार बीच में जाके इसको प्ले कर रही थी और फिर मैं म्यूट करती थी, फिर प्ले करती थी. मैं oh my god, I wish this comes later on that I can just go through it. And it was so nice. फिर जब मैंने करीम भाई को देखा, I was even excited. I was like, oh my god, लग रहा कमरान भाई भी आए दोबारा, इतना अच्छा होगा. And it was so nice to, it's not like we cannot meet, but it's just that जब आप जाते भी हैं Pakistan, it's just not possible that everybody will be there in the same point in time. Other than that, our expertise are different. So I think we all can do great things, not only at our individual own positions, but perhaps together. And I think we should do it. Like, for example, if Iffat needs something that should be done from US perspective, I am available. We should do something together. Similarly, if Kamran thinks that I should be able to do something, I'm from telehealth perspective, I should be able to do it. Similarly, I'm very sure, like, I learned so much from Mahmood bhai. Like, I was like, I'm not going to disclose it कि मैं क्या बना रही थी, but I was just making something. But all the portion controlled, but I was making something. So, and then मैंने play किया हुआ था, I was like, my husband was like, what are you doing? I was like, shh. Because I'm administrative. I need to learn administration from him. He's looking at me like, "Apni company khol rahi ho kya?" I'm like, "No, yeah, but I need to learn from him." So it's just so nice that everybody is doing so nice of a hard work, and it's so nice to learn. Like, I think we all are not only learning from each other, I think we are growing as a family. And it's nice to see each other growing as a family. And thanks to you guys for doing that. So, Alhamdulillah, it is so nice to see that the basement mein hum log padhte the. It really worked out nice.
Yeah,
I
we
think the nostalgic feeling थी और बिल्कुल आप सही कह रही हैं. ऐसा लग रहा है we all have like grown up together. और वो
Exactly.
perceptions change हो रहे हैं from those childish images that we had in that basement area to now being all grown up professionals in our own area.
with the basement, we were really close to each other. Now everybody was right next to us, So wherever we used to go, there was no place hiding. So
I still have like some of the residents in my program here in MedStar. मेरे हस्बैंड मुझसे पूछते हैं कौन से बैच का मैं कहती हूँ मेरे ग्रेट ग्रैंड 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 जूनियर है वो तूने ग्रैंड लगा दिए तुम कौन से बैच की हो we just talk about all this.
For 5 years, we were literally underground, and we can say that.
डॉक्टर मौसम बोलते थे ये वाहिद मेडिकल कॉलेज है जो कि मैप पे नहीं है.
No, we're going to share soon. We're trying to make our blog live, so people like talent and expertise like you guys can put in those blogs, so we can share. There's a lot of data of people. We have some tax officers who are Ziauddin alumni. We have some.
I know.
Yeah,
and that's what I was about to say. We should do something outside of medicine also. Like, it's nice to learn because
Actually,
people
yes.
have evolved in a lot of different ways. ज़रूरी तो नहीं कि आप MBBS करने के बाद you just be physician. Like, I mean, look at Kamran. I mean, he's a big man in a different way. And I'm like,
in next session, we are pushing to our ex-faculty to come live, like
Oh, that would be great.
We're trying to,
let's see who comes up. So anyways, nice to have you once again, and hope to see you again in different sessions, maybe with different people all together. Okay, so we're going to end our broadcast now.